Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you today. We're broadcasting live from the Dolph Simons Family Studio. On my right, of course, is Hawkeye. Thank gosh for that guy. Still here and still upright. On my left is Chris Wilson, our VP of System Integration and Innovation. We're delighted to have him joining us again today. On Skype, we have two terrific folks, KU alum and former Google Vice President and CVKey developer Brian McClendon is here. He's going to be talking with us a little bit about a pretty cool innovation that he and a co-founder of CVKey Marci Nielson, who has a history at KU here back a few years ago, I think, of working in our public relations and leading some of the public relations for the university. They are here to talk with us a little bit about what CVKey can do for you. We think it's a pretty cool tool. We want you to meet that tool and meet these two terrific folks who are helping develop that. And with Chris Wilson's advice and Doug Gerard from Lawrence and other members of the Lawrence community, trying to get it into the university as part of their daily life to help track and protect people from COVID-19. But before we go there, of course, we go to Hawkeye.
Yeah, I think we're still doing good. Our numbers have come down the last week, 10 days, and that's good because we are going into a holiday weekend. We know that Dr. Fauci has talked about surges or increases in cases that have happened after the holidays recently, Memorial Day, 4th of July. And again, those surges don't seem to happen until, we thought 2 weeks, but initially now it seems like it's more the 4 to 6 week range. So luckily the numbers in the hospital are low, 23 in the hospital, 6 of those in the ICU and 3 on the ventilator. We do have 5 patients, though, that remain on the ventilator that we consider from that acute phase, so kind of in the recovery phase. So we understand, for the most part, if you do get on a ventilator, it does take some time to get off.
Yeah, it can take a couple, 3 weeks, sometimes 2 to 3 weeks in order to wean yourself or liberate yourself from that ventilator, and it is a liberation when that occurs. How many deaths have we had so far?
Oh, gosh. I don't remember how many deaths, but we haven't had a death since August 27th.
I think we were at 57 deaths, and I'm not sure if it's gone up since that day.
There weren't any
tomorrow.
overnight, so it's been almost a week since we had the deaths, so that's really good.
That's great. Yeah. Okay, good deal. Well, Chris, help us understand what CVKey is and help us introduce Brian and Marci to our audience.
Sure. So CVKey is a digital tool that's helping the KU campus and other organizations right now. I'd be able to help screen individuals who might be COVID infected either before or after their symptoms occur. So it's a great way for organizations to help scale their ability to prevent the spread of COVID within the organization across large geographies like a college campus. And so Brian McClendon and Marci here are the co-founders of that work, and really excited to have them explain a little more about it and how it's a piece of a larger COVID prevention strategy and campus reopening in Lawrence.
All right, Brian, so talk to us a little bit about that, and talk to us about this whole Google-Apple thing. Google and Apple working together? Who would have ever thought about that being true?
Yeah, that's a complicated story, so we'll get to that in a few minutes. To start with, let me talk a little bit about our group and how we formed. So CVKey Project was formed in April, and we are a group of volunteers, and we're a 501c3 nonprofit, and we recruited engineers, experts, and IT and operations people to build an app that could be used to solve the health status, policy communication, and access control aspects of the COVID crisis. And as many of us know, going whether it's to a hospital or to a dentist or to a business, they want to ask you about your symptoms. And they have many different ways of doing it, from a paper survey to a verbal interview. Sometimes there's a temperature check involved, and that's slow. And it doesn't give, in many cases, enough depth of both question or answer. And so we built a software tool that is available on iOS and Android that goes through that process and allows a user to demonstrate what it looks like and answer these questions, as you're seeing on the screen right now. This is great. That they can quickly go through every day and face the questions about both symptoms and health. And I'll let Dr. Nielson talk more about that aspect of it. But at the end of this, what you end up with is a QR code. And unlike some other solutions to this problem, we were very privacy focused. So the information that you enter into the app and the answers to your questions are not exposed to the cloud, to any data store, to a company, or even really to KU. What the app does is check your health status against the requirements of one of these categories and says, do you have a health status that will allow you to get into the store? And then produces a QR code that you can use. So a CV Pass here. But before that, it shows you policies, and these policies can be customized for different buildings. And the University of Kansas has, different policies for different buildings, and they use this app to communicate that information. And what you saw there was a QR code that contains no personal information, but allows the system to know that you have taken the survey today. And now I'll let Dr. Nielson talk a little bit about the questions and some of the, the interesting challenges you have in getting, good, honest answers about it.
All right, Marci, you're up.
Hi, Dr. Stites. Great to see you again.
Good to see you.
As you know, I have a public health background. I taught in the public health program there at KU Med for many years. And no one expects a pandemic to rage across our country in quite the way that it has. We are trying to assuage people's fears about getting back out into public places, into the economy. And the way in which you do that is you ensure that people feel empowered. You give them information that is individualized and certainly privacy protected that lets them feel good when they're out and about. And so Brian mentioned the questions. We thought it was very important that we use the same questions that the Centers for Disease Control uses. We wanted to make sure that we were standardized to the best guidelines and healthcare practices. But we recognize there's a lot of importance in local guidelines, making folks feel safe that the information in the app is tailored specifically to them. So we also pulled in information from the Kansas Department of Health and Environment. And the challenges that we had were, how do you convert these scientific questions about symptoms, which sometimes feel very nuanced. So the question of, do I have the symptom of a headache, for example? Well, if I do, does that mean I'm at risk for COVID? Well, it certainly does mean you're at risk if it's a new headache, if it's a headache that is strange from what perhaps you're used to. As someone who suffers migraines, I want that questionnaire to ask me whether or not this is a new symptom. So we have continued to improve the symptom checker, as we call it, to ensure that the information that goes into the checker provides you with clear guidance on what it is you are supposed to do if you have, for example, these symptoms, or, for example, you've been exposed as you've been traveling, you've gone to an area that is a hot spot. So the symptom checker itself, as Brian mentioned, is just one piece of what this tool does. The next thing it does is it converts that information into a QR code. And so when you are at a class at KU, as my daughters are, they can know that the students around them have also gone through the symptom checker, and everyone that you are around, although you're still social distancing and wearing your mask, but everyone is trying to maximize everyone else's safety. And the final thing is, as Brian mentioned, communications within the app that not only tell the user, if in fact you have these symptoms, here's what you do next. And in the case of students at KU, obviously connecting with the health professionals at the Watkins Health Center. But they also allow policymakers like Dr. Gerard, who runs our university, to decide what he quickly wants to communicate to the student body and which buildings he wants to make sure everyone has access to, or he wants to restrict. So the app itself is really pretty unique. And you mentioned two of the founders, Brian McClendon and myself, but I'd want to give a shout out to the other two founders, Manik Gupta and Waleed Kadus. Brian's been able to recruit some amazing people. All the volunteers, we're up to almost 30 now.
Yeah, pretty cool stuff. And the Apple Google story is kind of cool.
So I can go into that. This is a long, complicated topic. So what you're referring to is the Google Apple exposure notification technology. And to give depth to that, first you need some background, which is that the goal of using an app on your phone to figure out exposure is a very cool idea. And one would think that, we have this phone in our pocket, we should be able to use it to know whether we've been near somebody who's infected. And all of the first attempts at this used GPS. And the problem with that, or there are many problems with GPS. Well, GPS is not really accurate enough to give you knowledge about location within 5 meters, let alone the 2 meters that we're supposed to be measuring. And that's outdoors. Indoors, it's even worse. It's also all sorts of privacy issues because your location track really tells a lot about you, so you shouldn't be uploading that. And so what Google and Apple did was realize this and use a different technology. And so think of this as Bluetooth pairing. So if for those of you who have a phone where you've paired your earbuds or some other device, it uses the same technology, but instead of saying, this is Brian's phone, connect to the earbuds, it puts out a random number that it generates, and it changes that number every 15 minutes. And the goal is, it puts this number out and is putting it out regularly. And it also looks for any other phones who are putting out a similar kind of random number, and it keeps track of them. But notice, no data is going to the cloud, no data is leaving your phone. So it just records this information in the phone. And then during the case notification process, after someone has been infected, a caseworker can ask the user, do you have this app installed or do you have this enabled? If so, would you upload your random numbers, the ones that you were putting out, up to the cloud? And then everybody else's phone downloads those numbers and compares them to the numbers they've been seeing over the last 2 weeks. And if they've seen those numbers long enough and strong enough, it's considered a contact exposure. And you get a notification on your phone. So again, in this case, the only data that ever got uploaded to the cloud was the infected person's random numbers that they were broadcasting. So nobody else's information has ever been uploaded. And at that moment, 2 hours after the infected person's caseworker is called, everybody else gets an exposure notification on their phone saying, you were near enough for long enough that we believe you've had an exposure, and it happened on Tuesday. You don't even get a specific time, so you can't identify who you were near because that's a privacy violation. So at that time, the state has the opportunity to give you information about what you should do next, whether it's call the contact tracing hotline, go get tested, or if we're in a sort of red zone and we don't have the bandwidth to handle this, you can immediately tell them quarantine in place for 14 days and, presume that you're infected and, wait for further instruction. And so the goal here is to allow states to change their guidance based on the capabilities of the contact tracing teams at that time. And so what with Google and Apple have done is they built this technology, but they are allowing each country to release an app. And so we've seen Germany, Switzerland, Ireland, and now several other countries release the app. And there's been a lot of success, in particular in Ireland, with this app. In the United States, they didn't believe they could convince the United States to choose a single app. So they said, states, you choose the app. And we have seen Virginia, North Dakota, and I believe Alabama launch. And we've had announcements of Pennsylvania and a few other states that are about to launch this app. And So we think this is a very important technology, and we would like to see it adopted in Kansas.
Yeah, it sounds really cool. Chris, it would make contact tracing so much easier.
Yeah, well, I mean, pandemics by definition involve millions of people and individuals, millions of positives, millions of close contacts. And so when you think about a workforce to be able to manage that caseload, really, it's pretty impractical if you think that all of us also had day jobs before the pandemic started. And so where would that labor force come from? And so operating at that scale, I think a digital solution for either symptom checking or contact tracing, especially one that respects privacy and takes privacy very seriously, is really something that we need to seriously investigate and take a hard look at. Because otherwise, I think it's going to be a challenge for us to manage this pandemic or future pandemics without really cutting into the available labor force that's we're trying to put back to what they were doing prior to the pandemic.
Yeah, big deal, and I'm all about it. What about you? I'm ready to load it on my phone.
Yeah, absolutely. If we can get something, I think that will help moving forward. That will help continue to get people to be doing the things they want to, such as church services, but also it may help getting students back into school in those districts and those communities where the levels of infection are so high. It may help decrease the spread and thereby get people back into school.
And I think I'd want to know if I was exposed to somebody, because that way I want to prevent, if I've been exposed to somebody and need to be tested, I want to make sure I'm not infecting anybody else. So that's really the glory of this, and I think would really help limit the spread. So that's a great development. Well, Jill, let's see what questions are out there this morning. Let's start with media.
Right. I have a couple of reporters who have texted me questions this morning.
All right.
41 Action News wants to know, can people get flu and COVID at the same time? If so, what impact can they have on the body? And does the symptom checker work for that?
Let's take a look at that. Great question. Let's start with the can you do it. Dana, I don't know that there's any reason you can't.
Right.
It's much more common in kids to get co-infection with one virus than it is in adults. And part of that's just the milieu that children operate in compared to adults. But I don't know that there's any reason to suspect we can't do it. We don't see a lot of that, though, so far.
We haven't. But again, remember, at the beginning of this pandemic in the United States experience, we were kind of in the tail end of influenza. We know that it can happen. We know that especially our immune suppressed patients, like BMT patients, we do see that, but it is infrequent. It's not as much as just a single virus, but we can see 2 or maybe even sometimes 3 different respiratory viruses in those patients. We certainly know that even if you aren't immunosuppressed, you are certainly going to be susceptible to co-infections with more than one virus, including SARS-CoV-2 and influenza infection as well.
Yeah, it doesn't have to just be influenza. It could be a different one.
Could be,
I mean, some of my patient population is cystic fibrosis predominantly. We see folks who may come in with RSV and something else like coronavirus or coronavirus and rhinovirus. I mean, that is not an uncommon combination in the middle of the cold season. So I think we just have to be vigilant for that. Again, the best way to protect yourself from that is the same pillars of infection control we preach every day. If you wear a mask, you wash your hands, you keep your distance if you're sick. Those are the things that are going to protect you from a double infection along with a flu vaccine.
And will it be worse? So certainly that is why we do want to promote and endorse flu vaccine now more than ever, because we don't know how it will be. Certainly your body is taking another insult. Your lungs are taking another insult. We know that with influenza, there are high rates of secondary bacterial infections, such as with Staphylococcus and Streptococcus. So it is vitally important, and it certainly could worsen your prognosis if you do get a co-infection, especially with those 2 infections.
And what do you think as far as any other preventative measures people can take, number one? Number two, have you seen anything from Australia? I've not looked at that to see if they've had a lot of co-infection. Maybe you've seen that.
I haven't seen anything for co-infections, but what I do know is from the Southern Hemisphere, particularly South Africa and Australia, they've had a very low influenza year this year. So they are kind of ending their season of influenza while we are going into ours. But I know that the Southern Hemisphere, particularly those 2 countries, have had very good rates, meaning very small amounts of influenza compared to, say, the last 5 years.
May it be so for all of us. Okay.
The second part of that was, does the symptom checker work for that? And then he has one more question.
Okay.
Well, I think the beauty of a digital platform for large spread respiratory illnesses would be that we can check symptoms for multiple conditions with that type of arrangement, and also be able to modify it relatively quickly. So we don't necessarily need to diagnose using a digital tool like that, but we can at least screen for symptoms that could be a potential infection for multiple potential viruses or disease or other infections.
Yeah, and I think that's a really important tool. So, Brian, have you guys thought, or Marci, have you all thought about trying to do that with this one too? Because it could have widespread use even past the pandemic.
I'll let Marci answer that one.
Well,
I hear she's nodding her head. Yep.
yeah, we have thought of it. I appreciate Chris's point about the utility of a digital tool. I think, of course, the beauty here is not only can the tool help identify your symptoms, but it can also share information, and as Chris pointed out, very quickly. So there is utility in the tool. The challenge, of course, is that many of the symptoms of COVID are similar to the flu. And so that's where you don't want to think what a digital tool can do. You still need to consult your physician or your healthcare provider when you are in question, and certainly when your symptoms are serious. So it's an education tool and a screening tool and a triage tool.
Yeah, it's all the above. And Marci, is that, I'm seeing the Metro map behind you, as well as is that the part of a sunflower that's back there? What's that thing going on?
Yes, that's my love for Kansas, as well as my love for our nation's capital. Thank you for recognizing my backdrop.
I saw that. That's pretty good.
All right, Brian's last question that he has from 41 News are hospitals prepared for increase in cases of combined flu and COVID? He's heard you talk about the 60 to 100 beds with COVID patients. Here
Well, right.
at our hospital.
Yeah. So to clarify, so what we have, and we've talked about this now. We give you both sets of numbers. We tell you here's our number of positive COVID patients that are in the acute phase, which is within the first 10 days of their illness when they're still actively shedding virus, and you take different infection control precautions. So when we report our data to CDC or HHS, or now back to CDC again, when we report that data, what they really want to know is our first 10 days population, and they want to know that because they're trying to measure where we are on any kind of surge. So and how they're going to distribute medications and PPE and remdesivir. So that all makes sense. So we report that number, and that number runs here right now. It's been going between 25 and 35, or the upper 30s for the last few weeks. And so let's say it's just 30, and then we have the number of people who are COVID recovering. So they're outside of the 10 days, but they're still in the hospital and they're here because of COVID. That number's been running around 30 for the last couple of weeks. So let's say that's a total of 60 of beds that are COVID-related beds. Either you're acute or you're recovering, doesn't matter. You've been here and you've got COVID, and you wouldn't be here if you didn't have COVID. 60 patients. The other thing we've had to do is take our semi-private patient rooms and make them single patient rooms because of risk or fear of spreading. We're trying to relook at that question and say, gosh, is there any way we can protect people in a semi-private room? But for now, let's say that's about 45 beds. So if you took 60 and you added the 40 that are kind of taken out when you convert those semi-private to private rooms, that means there's 100 beds in our hospital that have gone away because of COVID in an 800-bed hospital. That's 12.5%, right? So that's a big number for us, and so that's what we talk about. So the question is, I'm going to reframe it. It's not so much if you come in with both COVID and influenza at the same time. It's what happens if you have a bad influenza year and the COVID's increasing. I think that's a struggle, Dana. I mean, if I look at that number now, sometimes we'll have 25 or as many as 35 patients with influenza, but that's usually for a brief period. That happens for a couple of weeks. But even if you added another 20 patients with influenza, and let's say we're at 120 beds that have been changed because of COVID, that pushes up to 140, 150. Remember also that the winter it's not just influenza. It's metapneumovirus, it's parainfluenza virus, it's adenovirus, it's RSV, it's rhinovirus, which is a pretty mild one normally, or the normal corona, pretty mild. But in a sick population, we get a lot of patients here with viral-related illnesses in the winter, which is why our highest census months tend to be like January. So our fear is what's going to happen then if we haven't prevented the spread and if people aren't following the pillars of infection control. What we hope is that if people will follow those pillars, we'll be what Australia's done, and they'll see lower numbers, Dana.
Yeah, I think that's what we would certainly like to hope for sure. we are prepared. Again, if you do have a COVID positive, even if you have RSV or influenza, you're going to be going to a COVID unit. We may have to expand those units, but the overall is we are prepared. Currently we have the PPE. Who knows if we get into a surge, but we're okay on PPE. We're okay on critical drugs right now, especially if you go on the ventilator. But we just don't know what the fall and the winter is going to bring us. And so that's why it is so important to continue to maintain physical distancing, not meeting in large groups, and masking so we can really stop the spread. Not only to our children, as there are schools that are going back now and in person, but it's to those vulnerable populations, whether it's the people working in the schools or the people in the homes. So hopefully.
KCTV5 wants you to define close contact in terms of risk and quarantine. They want to try
They
to
want a clear. They want a clear
clear that
answer.
up.
Yeah, that's not an easy answer, Dana.
Yeah.
Go ahead.
Okay.
Well, I'm here for brother.
It is certainly down in black and white on the CDC website. It defines, it is really about proximity and duration. So how close are you to somebody and for what amount of time? Over and above that, if you can have masking on, that will help a lot. So how close are we talking about? Certainly the World Health Organization says 3 feet or 1 meter. The CDC says 6 feet or 2 meters. Well, the World Health Organization, again, we've addressed this, has to address their messages to a lot of different countries in areas where they can't separate. But that is the black and white. So the big concept is to remember is that closer proximity for an amount of time. Now, it has been varying between 10 minutes and 15 minutes. I believe the CDC right now says 15 minutes, and 6 feet or closer is a close contact, is a high-risk contact. Certainly we know from published studies and anecdotes that if both parties are wearing a mask, for instance, the hairdressers in Springfield,
that's a great
if you're
example.
wearing a mask, even if you're close for that amount of time, which will probably be 20 to 30 minutes for a haircut, I would assume, you will have less risk. So masking is very important, but the CDC really defines it as 15 minutes closer than 6 feet. But again, that is black and white. It's more important for the general public to understand these concepts. And the concept is if you can stay further apart, that's better. Masking is absolutely better, again, for both parties. And for a short duration of time, you will have less risk.
Yeah, Marci, I saw you shaking your
Yeah.
head. Anything you wanted to add to that?
No, I think it's important to point out to the public that it feels like there's debate in the scientific community, but in reality, it is understanding the concepts.
Yeah.
It is about duration, and it is about being close, keeping a mask on, critically important, trying to be outside. So, yeah, it's kind of basic prevention messages that the folks need to focus on.
Chris?
Yeah,
I'm sorry, Brian, go ahead.
One thing, which is that, I've read a lot about this, and, the difference between inside and outside really matters. Some of the studies are saying it's 19 times more risky inside than outside. But really, that's about ventilation, and you're starting to read more about ventilation in buildings now, and I think that's also important. But I like to say that, Kansas is the best place in the world to prevent COVID, because when you're outdoors in Kansas, your ventilation is perfect.
Yep. The wind
Saudi
blows.
Arabia.
The wind blows.
Wind, that's
right.
Yeah. I appreciate the question because there are a lot of different standards out there from different organizations. And, they say politics is local. Well, close contact definitions can be local as well. So in the state of Kansas, Kansas Department of Health and Environment uses less than 6 feet for greater than 10 minutes. And so they have an even stricter definition than the CDC has right now. And that's the time and duration that the local health departments will be using when they're doing their contact tracing and disease investigation that might produce someone being placed into quarantine as a result of that. So if you're on the Kansas side of the state line, I would look at the less than 6 feet for greater than 10 minutes is what your local health department would be using to define a close contact.
Yeah, and you can see that if you stick around for the full broadcast. We'll show you a little. We're back in the freezer again with some really cool technology that will help illustrate this point, and I think it'll make it a little bit better. The truth is this. There are a lot of variables that affect the answer to this question. And to that reporter, it is an imperfect answer, because the bottom line is the closer you are, the riskier it is. After 6 feet, probably pretty okay, unless you're exercising, you're breathing hard, or you're singing in a choir. In that case, it may be 10, 12, 20 feet. So the bottom line is, the further apart you are, the better off. The closer you are, the riskier it is. And the closer you are, you better have a mask. Outside, always better than inside, because wind currents do funny things to the breath, and it disperses it and goes all around, as opposed to having your breath cloud leave you and just sit there. If there's no movement of the air in the room, the breath cloud just sits there, and somebody else walks through your breath cloud, or is close to you, you're talking to each other, and your breath clouds are interacting, and pretty soon you got each other's germs. That's just how the germ factory works. Marci, Jill.
Yeah, no,
I know
no
names.
problem. I love being called by her. She seems very smart and pretty. So I like both those things. I want to get to community questions because they are really rolling in. So let's see what we can rock through. First, Sally wants to know, how reliable is the data that users are entering, and do you trust their inputs?
Let's go to Brian and Marci. Guys, how reliable is that data?
So I think that that is the question that we face no matter what, which is that whether you have a policy that isn't enforced, or you have a tool, or you have this scanning of QR code, it still depends on people being honest. And I think that it depends, but the goal of the app is to walk people through the questions, explaining why the answers are important. And in the case of KU, tying it back to their KU pledge, which is that they're going to do everything they can as students to prevent the spread of COVID. So the hope is they will be more honest, and the use of the app will make them more honest. But it does not make you safe. No promises here. CVKey helps make you safer. And I think that's all we can do in COVID. It's all a statistical battle, and we're reducing the number of people who are interacting, who are exposed or symptomatic, because we make them aware more quickly of what their next steps are, rather than eventually finding out that they should have stayed home today.
Donna wants to know, how many people have to upload the app to make it really effective?
Oh, great question. Marci, what do you think?
Well, we're talking about two different apps. So in terms of CVKey, which is that access control app, the number of people who use it is better. More is better. Thank you. That the app on the screen is the app I'm referring to. In the case of KU, Brian mentioned the KU pledge. So students, faculty, staff are all using this. The more folks who are using it, the more you can be assured that your colleagues and friends aren't, in fact, carrying COVID. But Brian said it can't guarantee safety, but it does make you safer. This is all a game of minimizing risk. Mm-hmm. I think the question that Donna may be asking is really more about how many people need to upload the exposure notification app. And in that case, Brian has really dug into the numbers, and I'm gonna push this back over to him.
All right, Brian.
Yeah, thanks, Marci. And to reemphasize, this is a different app, and this new app doesn't exist in Kansas yet. There is an app called COVID Watch in Virginia that is the solution for Virginia, and there's a solution in Ireland that each of those residents can download. But the goal would be for a Kansas app and a Kansas solution to be installed, obviously, by as many people as possible. And the basic answer is, if it doesn't reach a sufficient installed base, it's not really useful, because the challenge with it is that it only works when both people have it, the infected person and the exposed person, because otherwise you won't find out about this information. And so if you look at the numbers, at 10%, you'll only find 1% of the exposures. But at 60%, you'll find 36% of the exposures. And that's a much more powerful improvement in the contact tracing efforts, because all 36% of those exposures will get notified immediately on their phone after the infected person tests positive. And that latency from the time the person tests positive to the time they get notified is much faster with this app than anything that manual contact tracing alone can do, because those phone calls outbound take up to 48 hours. And in many cases, you don't know their names or phone numbers. You weren't familiar with the person that you were talking to that day, but the app will know. But again, I think the gold standard is if we can get it up to 60% installed base, then I think we'll have a huge impact on the curve. But even at 20 or 30, this combined with masks, with social distancing and good practices, contact tracing, and more testing, all of that combined can reduce and crush the curve. And so, there is no single golden solution. Even vaccination is not going to completely solve this. And we need to add all of these things together to get rid of COVID.
Yeah, I like that idea of crushing the curve. That'll take care of COVID weariness syndrome right there.
Okay, I'm worried about Joe Ellen, and Mary Lee out of Skidmore has a question that kind of dovetails. Joe Ellen says, I'm a musician over 70 with high blood pressure. We are starting rehearsals soon, indoors, approximately 50 people. All will be masked. How safe am I? And Mary Lee says, could you define large groups?
Yeah, okay, here we go, guys. We're going to take a shot at this.
Yeah.
First of all, Dana, starting indoors, my first question is how far apart are you, and are you going to wear a mask?
Yeah, absolutely. There has been some looking at this. There is active investigation and research into this particular things for symphonies, for singing. We still don't fully know the answer. We know that some instruments are able to, particularly the wind instruments, as opposed to the strings or violins. But we know that they can disperse different sizes of particles compared to singing or talking. We still don't know exactly how far, so that is a danger there, especially if the particles are smaller. Are they able to stay in the air a little bit longer? There is variation in those things, particularly with things like trumpets, trombones, things of that nature.
It's probably hard to play those through a mask. Just
Right.
guessing,
Yes, absolutely. And then singing, which is also difficult through a mask. So singing, we know, can also express more particles for a further distance at all compared to just talking. So, it does lend to be a little bit more risky for sure. I think, if you can be separated and are doing the singing, that is safer, but sometimes that can't be done. We know that from the CDC publication, there was an outbreak in that situation of choir practice. Now, there were also some caveats there. Were those people actually together doing other things, not singing, such as eating close together, things of that nature? But it is a little bit more risky, probably.
Yeah, so we would think. And we've seen that in the freezer when we've tried to sing, right?
Yeah, exactly.
Yeah, it doesn't sound good either.
Sorry, and interestingly, there is a study in Germany right now that is going on where they did pack an auditorium full of people to watch a concert and do things like that. So, again, there is actually active ongoing research about these things because people do want to get back to a normal life. So, hopefully, moving forward, we will get more answers.
I would just say I would not have been a volunteer on the Pack the Auditorium plan in Germany to see how that study goes. I think my answer is this. If you're more than 6 feet apart and you're wearing a mask while you're, especially if you're a wind ensemble, you're probably doing the strings, things like that, as Dana was saying, then I think, that's a lot safer. If you're there and you're playing the brass instruments, I was a French horn player for many years all the way through college, if you're doing those kind of things, oh man, then I want to know how far apart you are. And if you're close together and you're doing a practice, as I would guess you are, so you can follow the conductor, and you're in a room and the room doesn't have great ventilation, which is typical of most orchestral rooms, then, I'd be a little nervous about that situation myself. So that's how I would look at it.
I played saxophone. If I blow through it, does it come out?
Well, it can. That's the point. That's what we're trying to find out a little bit more about.
So there was a pretty good, and again, for some reason, a lot of these are done in Europe. There are a couple seminal papers, and one of them did look at actual particle sizes that do come out of, and I think the trumpet was one of the instruments that had more of a dispersion and variability of sizes of particles that were able to come out and microaerosolize those.
And I'm going to guess things like a piccolo or flute, which have a straight line, probably will have a higher a mass amount and get out. You take the French horn, it has a lot of curves and winds, and there's going to be a lot of barriers that runs into. So there's a lot of physics involved.
Yeah.
We just got to have more information.
Melissa wants to know what you think about the CDC telling states to be ready for distribution of a vaccine by November 1.
Okay.
Yeah.
So I read the CDC stuff about this last night. We all three of us could take a shot at this one. I think this is a hot question. Number one, we have to make sure the vaccine's safe before it goes out, especially the two that are talking about coming out first, which tend to be a brand new technology, like using mRNA technology.
Yeah.
So I think I'd say let's make sure that thing is really safe before it gets out there. Number two, creating the network for vaccine distribution is absolutely the right thing to do. And if they're setting a target date of November 1st, so be it. Because what you're really saying is let's be ready, because there's going to be, I think, a significant rush to people wanting that vaccine. There's also data already out there about what are the 4 phases of what group gets the vaccine first, and it's really defined by how close your proximity illness, like healthcare workers, how sick you are, how healthy you are. It layers it out across those 4 phases. But in order to get the vaccine distributed, you have to have a way to distribute it. You got to have a methodology based upon the viral and where it is in the public and the degree of illness that people face. And I think that's actually one of the things they're trying to say. If you go back and look at what Fauci and the CDC are actually saying, what they're saying is be ready by November 1st because we want you to have a plan in place. And I don't know, Chris, have you been looking at that too?
Yeah, I heard a story this morning that said the distribution of the COVID vaccine could be the greatest logistical challenge the world has ever faced.
Yes.
Because just the scale and the volume of people that will need to receive the vaccine, and also the triaging of the different populations based upon risk that need to receive that vaccine in a priority order is a significant effort. So totally agree with everything. We need to make sure it's safe and effective before it's distributed. But the distribution process, I think, will be the bigger challenge, which is saying something, because the effort that's gone into the vaccine research and production so far just in the last several months is unprecedented pace for vaccine development.
Yeah, and let's remember something else. Back on this program with Senator Moran, months ago, I believe in May, we spoke about the potential for a vaccine to be ready as early as late October. That was from Francis Collins, the head of the NIH. The timeline hasn't really changed, and Francis Collins was quoted yesterday saying, again, it's probably going to be November. Well, or late October. Well, it's the same thing he was saying back in May, because they know that some of these studies look pretty good, Dana. So
Yeah.
I don't think that this idea that there's going to be a vaccine out, they're trying to rush it because of the election. Let's make this apolitical for a minute. Let's just remember that very reasonable people who are in the highest ranks of scientific rank in this country said in May that we would have a vaccine potentially in late October and early November.
Yeah.
This is actually not new news. It is not new news. It's just gotten a little bit more popularized because of the election, I think.
Yeah, and we know that vaccines have had a history of being delayed. Even things like the Shingrix, which is a shingles vaccine, there was a shortage for a long time of that, and we were unable to get it. A lot of clinics were unable to get it. Every year there seems to be either a delay or some sort of logistical problem with the influenza vaccine. So this is not...
It's not a done deal.
This is nothing new. This is a huge undertaking. We know that around the world, vaccination programs have problems. So we aren't even just talking about the United States, which could have an issue, but vaccinating people around the world can be an issue. We know that's an issue every day in many countries around the world for many vaccinations. But the interesting thing about this is we are saying a vaccine. There's still no answer as if do we need more than one vaccine? Are there going to be 2 or 3 that we may need to get? Are we going to need a booster in 6 months? So those are questions. So even the initial rollout is going to be daunting, but even continuing to follow that up is going to be daunting.
And there's so much organizational work. That's why I'm thinking be ready by November 1st. But you have to be ready for the vaccine, a repeat vaccine if you need a booster, and you may have more than one vaccine. Yes. So this is going to be a crazy undertaking. So yeah, let's go get ready. I have no problem with that. One more question. Brian.
Can I interrupt for a second? I've never had the opportunity to ask medical experts this question, which I think is important, which is that the vaccinations that they're going to approve are being talked about as if it's greater than 50% effective or greater than 70% effective, that will be good enough to go out there. And I think I understand this, but I would love to hear your explanation, which is that for the MMR and the kids' diseases, they really are 99% effective. They're really good at shutting this down. But a 70% effective vaccine that I take does not allow me to change my behavior at all. It reduces my chance of catching COVID, but it doesn't negate it. And so I still have to wear a mask and still have to socially distance. And we all have to do that until enough people have been vaccinated. I mean, is that correct?
Yeah, I think it is. I also think it's a question of relative risk, right? Mm-hmm. We've been trying to encourage everybody. You have to weigh your individual personal risk around what your mental health is like, what your bubble's going to be like, how you're going to function in your life. And I think that is largely a personal question. And I think the vaccine helps you address some of those personal issues. Having said that, I'm with you. Wear a mask, socially distance, do the things you have to do until we've gotten, because the whole point of doing this is that eventually we push coronavirus, SARS-CoV-2, into a situation where it kind of disappears because there's not new people to infect, Dana.
No, you are absolutely right in what you said. And if we look at influenza vaccine as compared to, say, hepatitis A vaccine, where we know that after one dose of hepatitis A vaccine, 90 to 95% of the people get immunity. There is a second dose that's required, but it is a very good vaccine. Compare that to influenza. So with influenza, we hope for 100% viral vaccine efficacy. I think in the last year, I could be wrong, but it was about 40% efficacious. And that was the total, because in the influenza vaccine, there are 4 different strains that they carry. So within those strains, there were different amounts, but the overall efficacy of that vaccine, I believe, was 40% for the last influenza year. And what that means, to your point, is exactly, it reduces your risk of getting the infection or severe illness by that much. Now, it could protect you fully, but the overall is to help reduce that risk of illness so that you don't miss work days, severe illness so that you don't have to go to the hospital and be on the ventilator. But overall, you were exactly right in your point.
All right, Judy gets the last question.
Last question.
She watched the broadcast yesterday with the CMOs, chief medical officers, and the community update. She said it sounded dire, and she wanted you to speak to it. I'd also like to take this opportunity to let people know we will re-show that broadcast on Monday, on Labor Day, because we won't be here, but we are going to show that again. But can you talk to that?
Yeah, I think it's dire if we don't act responsibly, right? If we can act and do the things, if we can be KC, if we can wear a mask, socially distance, limit our crowd sizes, I think we have to expect the best. That'll allow us to expect the best. But if we don't do things, then it can be bad. And that's what Dr. Birx was saying to us. Don't become Georgia and Florida and Alabama. You have the chance to bend it now, or as Brian has said, crush the curve. Take every type of thing that you have available in your arsenal, masks, distancing, CVKey, all sorts of different things, to try and make sure that you keep yourself and your loved ones, your family, your friends, keep you all safe. You have the power to do that. And we all have cows, right? We're all tired of it. We all just want to go out and do the things we want to do. But as Travis Kelce taught us, you have to fight for your right to party. And the way you fight in this case is to follow the pillars of infection control. That's the fight. And it's really a very individual battle. Do you choose to do that? Will you get past the things you want to do and realize to do the things we should do? If we can do that, we can stay safe and we won't be dire. But if we don't do those things, it can be tough. And that's what we're trying to prevent. But we all have the power. And the real key is that there is real help on the way. Whether it's contact tracing programs like the ones we've talked about today, or the vaccination that's coming, or vaccines, I think they're going to be really successful. Again, This coronavirus isn't hard to track down by vaccination. And again, Dr. Birx has told us, this is a pretty easy virus to attack through vaccine because the spike protein is what it's all about. And if the virus doesn't have the spike protein, who cares? Because then it's not going to be the same virus. So we can do this. We just have to be patient and ready to follow this new norm for a little longer. And if we can do that, we can keep each other safe. We can beat the virus. And we can have schools and businesses open as long as we can follow the basic pillars of infection control. It all comes back to the same story every single day. Hey, I want to thank everybody for being here today. Brian and Marci, a delight to see you again. We'll keep trying to talk about this because I think this is a really important tool. We were talking about this in the health system the other day. We have employees who may not want to miss work and they come back and they're a little sick, and the answer is no. Let's use something like CVKey to help screen those folks. To Chris Wilson for being back. He'll be back with us more coming up. And of course, Hawkeye. Hey, tomorrow Hawkeye are here. Hawkeye and I are back. We're going to be answering your questions. It's Question Friday. We also have Dr. Christy Bartlett from Palliative Medicine will be on our program. We want to talk a little bit more about this whole thing, about the real death rate of COVID and why sometimes death certificates aren't the best way to answer that question, and that we are telling the truth. We are not hiding a darn thing. So we invite you to be with us tomorrow about that. We'll talk more about that. Also, remember to send us your mask photos. And as Jill pointed out, on Monday we have a pretty cool deal going on because we're going to rebroadcast the CMO conference from yesterday. And I know the CMOs will be back on our program joining us in the not so distant future. And when we do that, well, I'm sure we'll have questions about what we said. So
September
we're always
21st is the next time
September
they're back.
21st. All right, there you go. In the meantime, send us those mask photos, and we have another cool video to share because Hawkeye and I, we're back in the freezer again.
The trilogy.
Yeah, the trilogy. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System. I'm back in the freezer with my good friend, Dr. Hawkeye.
Hi.
We're here to make a point about masks. Doc Hawk, he's got his surgical mask on. I've got a cloth mask. But you know what? All masks can help keep us safe. And you can tell if you don't see our breath. We take our masks off, and what happens? Now we talk. There's our breath. We take a deep breath. Man, I've got your breath in my face.
My mask doesn't work well here.
What if we just put it under our nose? Does that really do any good? Not so much. So remember, let's keep each other safe. Let's keep our masks on.